As every speaker should do, it's very important to determine what our disclosures are, our conflict of interest. Mine is Florida Probe, Peri-Implantitis, Biolace, Phillips, Ufredi. And so over the last year, I've received something, whether it be a toothbrush or a scaler, curette, from one of these particular companies. And throughout this, this will be a non-commercial type of event, but every now and then you might see me sort of suggest something that I believe that I use or that you might want to use to make this thing more effective. Now, in our brief time together, what I would like for us to accomplish is definitely something that we call interactive. In other words, I may say some things that some of you may get an arrhythmia over, some of you may enjoy, and some of you may agree with. But what we want to do is sort of take a really solid look at this thing called mucositis versus implantitis. We also want to take a look at what do we want our patients to do at home for their oral hygiene relative to this new design that goes beyond just our natural dentition. Naturally, we are in the dental profession, or what I would like to say, the oral health profession. And with that, if I'm listening or watching, I want to know some techniques that I can use at the chair for both mucositis and implantitis. And when you see this, I've sort of divided this up into about 40% mucositis, and the rest is 60% will be implantitis. And then at the end, we want to establish the current and future role of possibly dental lasers in various areas from mucositis to implantitis, and also looking not only from a open type of procedure, but also from a minimally invasive closed procedure. Implants are nothing new. They began way back in 2000 BC. If you're into implants, you know that what really made the difference was Dr. Brannemark. And as an orthopedic surgeon, I can recall when he was creating ears and noses and using somewhat of a hybrid endosseous implant. Then we went into titanium, and in the recent, it's primarily the buzz has always been what we call the all-on 4 or the all-on 6. Implants are here. They're not going anywhere. They are in the armamentarium of probably almost every oral surgeon, periodontist. Now definitely into the armamentarium of prosthodontists, endodontists, and especially our general practitioners. Patients are now knowing what implants are. We're placing a lot of them. From a vendor perspective, it is significant dollars. But at the same time, we're starting to think, well, maybe not, it's not totally the panacea for everything. And there possibly is a failure rate, and we'll have that conversation. But all of us are focused on stabilization, supporting structure, and the aesthetics. Now, if you and I compare a tooth and an implant, for the most part, there are similarities, but there are significant differences. When you see the tooth, I would suggest that the cementum, PDL, and bone are a major difference for us. And when you look at the implant, no PDL, no cementum, no bone, and actually the supracrestal fibers are more of an adherence rather than an attachment. And when we begin to talk about this thing called probing implants, that will become important to us later on. But my goodness, do we have complications. And from a restorative aspect, those complications can be from fixture loss to soft tissue reactions to fractured components. I mean, when you look at an implant, if you look over on the right, when you look at an implant and you don't really think about what's in there, but there is a lot of things in there. And for many of you, you're very aware of something called the screw fracture. which is basically purgatory, at 4:30 on the very last day of the week of your practice. And so as we do that, for the most part, the American Academy of Perio has always recognized implants, but it was not until recently that, in the scheme of things, that we began to have a conversation about peri-implant diseases. And I was very gratified that in the 2017 World Workshop, which was our new AAP and total global classification of periodontitis, we now included implantitis. And with that, there became a certain degree of what we call implant-related periodontal diseases. And those diseases are implant health, implant mucositis, implantitis, and a very interesting new group called hard and soft tissue implant site deficiencies that we are also going to have that conversation. Let me begin that irrespective of what some folks believe, I've never believed that biofilm was the total reason we lost natural teeth, nor do I still believe that biofilm is the total reason we lose implants. So I'm sure that has risen to the gesture level of possibly arrhythmia with some of you. Agreed, it is critical. But this thing of infection versus inflammation is something that you and I are going to need to truly take a good look at. So yes, I could simply divide implant-related diseases into implant mucositis and implantitis. And for the most part, that's sort of what we're going to do today. So let's begin with our peri-implant mucositis. I like to call it the gingivitis of the implant game. The presence of inflammation combined to soft tissue around the implant, no sign of bone loss. Presence of probing greater than 4 with bleeding or suppuration. Every now and then I've seen 2 or 3 millimeters with significant bleeding and suppuration. And hopefully, for the most part, it's reversible. I would suggest one thing to you about mucositis, however. We sort of know, going back to the little studies about gingivitis and how long it takes to get it and how long it takes to get rid of it. And if you're a periodontist, you remember that back in your residency when we went over those studies with the dental students. But for the most part, when we take a look at this, that 2-week window, maybe 2 to 3 week window, doesn't really work for mucositis. My point is that even when you remove the biofilm, we know that it takes probably a little longer than that 3 to 4 week period to really begin to see health. No one likes to see this in a practice by removing the overstructure. However, it does occur. And there are many reasons for that that you and I are going to have a conversation about. And so when we take a look at that, I guess we could blame everything on oral hygiene. We've always done that in perio. And for the most part, I guess we could blame everything relative to implants on oral hygiene, as we did with periodontitis. But I know that you and I on this interactive session are smarter than that. That there is multivariables in both periodontitis and implantitis. But I would suggest to you, and you're going to hear me speak to this in a moment, that when you see these kinds of prosthesis, and if you're not going to be able to remove the prosthesis, you and I have an interesting challenge and a dialogue that we need to have a conversation about before this is over. So when I look at the American Academy of Periodontology, and I look at those risk factors, it's very definitive and possible. What I've outlined for you for definitive is that which we know that are definite, that we know we have research on. I mean, good research, good RCT, good blinded studies. Where you see possible, we're not totally sure. It's not that we're going to ignore it, but we're not totally sure from a meta-analysis systematic study. So therefore, let's you and I take a look at what you and I are going to do at a chair. Whether it be a dental hygienist, whether it be a dentist, periodontist, oral surgeon, prosthodontist, endodontist, what do we look for when we are looking at that implant? Well, the first thing is probe. I mean, my goodness, I live and breathe by the probe. In fact, I notice I even have one by my computer right here. Maybe it's just the way I am being a periodontist. I can't live without my probe, but I'm sort of wondering about when I probe implants, basically, what am I looking for? Well, I know I'm looking for bleeding and suppuration. That's a fact. But sometimes I've always said you can get bleeding anytime if you work at it. Suppuration is a little bit different. But all joking aside, just barely touching the inside of a sulcus and getting significant hemorrhage or suppuration on an implant is not good and generally telling us it's inflammation. But I'm not so sure we should be reading the numbers. I guess that's my point. In other words, I'm starting to think that maybe when we probe implants, maybe we shouldn't be trying to look at the numbers consistently because they're not consistent. And I'm going to show you why. There are times I probe implants, I'll get 12, 10, 20. And yet some of it's pseudo-pocketing. The real issue here is going to be radiographs. And by the way, I would always evaluate the occlusion and the prosthetic stability. And recent studies are showing attached gingiva is important. Please, attached gingiva is important. And when do you want attached gingiva? Before you place the implant, not later. So we have great probes out there. Some prefer the plastic probes. I prefer them not about the fact of affecting the titanium. I like them because I can sort of get around some of the convexities of some of these restorations. And this is a good example. There is not one of you alive that has not tried to probe an implant and got hung up on the convexity of that crown. So it is difficult to probe these things. So I say, probe them if you would like. Don't depend upon the numbers to a certain degree. Should help you in somewhat in treatment planning, but I rely on bleeding and suppuration. But the most critical part of all of this is accessibility. And I want to talk to the hygienist for a moment, because you know this better than anyone. I mean, trying to get things under implants is really a challenge. And so that makes it to where we should have prosthetics that for the most part create accessibility, not just for the patient, but also for the individuals that are going to be doing something called biofilm. So I always recommend whenever you can remove the prosthetic, please do. It is critical because now you can take your probe and actually be parallel to hopefully the long axis of that implant. But my friends, it's radiographs and they have to be done well and they can't be foreshortened and they have to be standardized and they have to be taken periodically because you've got a great probe here. You know what it's called? Threads. And you can determine where you are bone level wise to a certain degree by these threads and the relationship to the abutment. So with that, attached gingiva. There is no way a patient is going to be able to maintain these implants. Every time they touch it, it's going to be red, irritating, bleeding. And so therefore, we've got to have attached gingiva. So let me go into a couple of things for you. The first thing I want to go with, what do we want a patient to do at the chair? And what do we want us to do at the chair? When I say chair for patients, I really mean the bathroom. So I always say, what do I want the patients to do in the bathroom, and what do I want you and I to do at the chair? So let's talk about them in the bathroom or wherever they may be doing their cleaning. Unfortunately, I have noticed that many times they are doing this while they're in the car. They may not be texting, but they are cleaning their $5,000 to $6,000 implants that you placed, which is somewhat good. So let's go through some of these things. You know, I could probably provide you with an hour on oral hygiene maintenance for an implant because everyone has their tricks. But you know really what the bottom line is? What can they use and do it user-friendly? Not what you can use, but what can they use? What are they actually going to use every day? By the way, almost all studies demonstrate that all quality oral hygiene should be done at night. There's a reason for that. The mouth is closed. There's a certain level of desiccation. There's decreased salivary flow. So if I could give you a pearl, please, all quality oral hygiene should be done at night. I always tell patients, you can do whatever you want to in the morning, but at night you're mine. Well, this looks good for a photo, but if you got some patients that can do this I gotta see. And I know this patient's working hard, but patient didn't do this, hygienist did this. So we may want to be more practical, don't you think? Let's be more realistic. And in that, by the way, there has been some studies. Here's one I pulled out. Dental floss is a possible risk for the development of peri-implant disease. An observation study of just 10 cases. But you know, a tooth and an implant are different. For the most part, a tooth is sort of smooth. An implant, especially getting past that abutment, we're getting rough, especially when there are threads. So I'm not so sure we want to be using these kinds of things around implants because we do not know what's under there from a prosthesis standpoint. These are my favorites, and I don't care who makes them, but this is manna from heaven. These things are phenomenal for getting around areas. I love them. I love these things. Of course, if you're into perio, you live and breathe by interdental brushes, and my goodness, doesn't this seem such an easier task for a patient than what we just saw with the floss? So these are the things that I highly, highly recommend for accessibility to be able to get endo and do what you need to do. And you can choose. You can choose whichever you want. Now, almost all of our devices now, the threads, the bristles are all coated. And so there is really not an issue in scratching implant in this day and time. It was probably a decade ago, but not now. But that's what that patient's going to have to do every single day. By the way, you might notice right over here where you see some inadequate attached gingiva, which makes my very point of why you need attached gingiva. I don't care who places it, but place it before you place the implants. And then one of my favorites for the last 20, 25 years, and I'll probably shouldn't be doing this, but I love them. And they're out of Canada, and that's Sulca Brush. I mean, what a device. It is outstanding for any of these kinds of areas for both natural dentition and for implants. They are just absolutely excellent. And if I had my way, it's electric toothbrushes. Doesn't matter to me which one you use. I like those that have science. But I think electric toothbrushes are the way to go for patients that have implants, whether it's a single implant, whether it's all on 4, all on 6. I love electric toothbrushes, especially those that have timers. I sometimes say the first time you used a electric toothbrush that had a timer, that was probably the longest 30 seconds of your life. And it does not matter to me what else you use, but I think there is something to oral irrigation. Whether it be the numerous oral irrigation devices that are out there, or whether it be some of these new devices that actually uses photoacoustics by mixing air and water. I personally like to put things, medicaments in whatever device I use. It just makes sense to me. I don't really care what you use. Recently, there's been a move towards essential oils, menthol, thymol, etc., that you may want to consider. And so the rinses that you use is totally up to you. From that standpoint, these are just some of the things that are out there now. One of my favorites is something that has antioxidants in it, and that's the Peri-Implantitis, but it's really a personal preference and really up to you on what you do. But I think that rinses used appropriately are adjunctive to the mechanical. I've always believed that the way you do quality oral hygiene is what I call M&M, mechanical, medicinal, mechanical, medicinal, mechanical first, followed by medicinal. And if it were me, I would put these medicaments on my brushes. I would put them on my Intuff brushes. I would put them on my interdental brushes. I really believe what we're trying to do is truly have a decrease in recolonization of the microflora. But it's not easy. When we talk about removing the overstructure, the overdenture, what have you, every year, I don't know. I mean, does the microflora go on vacation for a year? I mean, should we be taking this off every 3 months? By the way, no one knows, but it just makes sense that we probably need to do it more frequently than every year. And I think you are starting to see that some folks are now thinking about removable over fixed. And we may see a little bit of a trend going in that direction if we start to see a peak with this implantitis. So for you at the chair, I think these are fine. I wouldn't think about it, but that's up to you. Because now you're starting to see the candor. I'm not so sure what these do. I've tried my best to try to develop a rationale for them. I'm sure that it probably doesn't have an adverse event unless you're trying to do curettage. But in my mind, I question them. And in my mind, I question also using not only some of them, including even the titanium, but also the ultrasonics. And unless you have something on that ultrasonic tip, like a polymer, ceramic, please, please, please be careful. Or before you know it, you're going to carve your initials in the side of the abutment. And so now we do have studies suggesting be careful with your ultrasonic. Be careful with your curettes. Be careful. And that's why I am beginning to believe that the future, present and future, of managing implants in the dental hygiene operatory, from the standpoint of what we do at the chair, is some type of medicinal airflow. And there are several products out there. You do not have to be dependent on any one device. This is some of those that are out there now. It's what you put in there that also makes such a difference. And when I suggest what you put in there, everything is going towards erythritol or glycine. Now a little bit more towards the erythritol, plant-based sugar, than the glycine. If you've used these, you know that the particulates are incredibly small, 15 to 20 microns compared to 60 microns. And by the way, please do not use sodium bicarb around an implant. It's going to etch it. In fact, I'm not so sure you want to use sodium bicarb around anything except maybe stain on the Marlboro Man on the enamel. Don't use it on the dentin, please. It will erode it. I'm asking you to keep an open mind and start thinking that these kinds of devices are going to be where we are. The science is behind them. And by the way, when I manage implantitis and even peritonitis with flaps reflected, I'm using these devices also for decontamination, degranulation. So please take a look at these in the future. And here's why. Here's our patient. By the way, again, one of my pet peeves, if you look over on the left, with attached gingiva, and that's the patient 30 seconds later. I mean, it is amazing that here's our patient 30 seconds later using some type of airflow device with either erythritol or with glycine. Highly, highly recommend this for you. So this is about biofilm management. This is about being able to remove biofilm, or one of my favorites is disrupt the biofilm. And this is what you can achieve by using these kinds of devices. So in the implant maintenance system, I'm indebted to Tim Himpton, who in 2012 suggested that there are 3 classifications of maintenance. And by the way, when I finish, I'm going to give you my email address. If you want a copy of this, I'll be more than happy to send this presentation to you. But on a class 1 with no exposure of basically the abutment to a certain degree, it's air polishing, laser bacterial reduction, and ultrasonics only if it's supragingival calculus. However, when you get to the class 2, and the titanium abutment is exposed to the oral cavity, as you see here, then you need to go a little step further. Still ultrasonics, if you can see the supragingival calculus. Still laser bacterial reduction, especially with our diodes. Laser degranulation, but only with erbium and CO2. And this is where it gets personal with me. Please do not use a diode on your curettage settings, your laser-assisted periodontal therapy settings around an implant. You will heat it. Then you'll heat the titanium, and you possibly can cause deosteointegration. If you want to use your laser diode around an implant, please only on continuous, uninitiated tip. When it even smells, looks like it's going to get initiated, wipe the initiation off, but don't use initiated diode tips around implants, especially for curettage. So in class 3, scenarios like this, again, it's very identical to class 2, except you're probably going to go a little deeper, but again, the same is your laser degranulation is only with erbiums or CO2s. So now let's move towards the remainder of our program with implantitis. Implantitis, there's got to be bone loss. There's got to be radiographic bone loss. And in that, when you start using your periodontal probes, you want to coordinate your probing with what you see. Now, I want you to begin to look at something. I want you to begin to look at the osseous bony topography of all these implants that have implantitis as we move forward. And I want you to contrast that with what you see relative to periodontitis. And I'm going to make an observation for you. When I see lesions that are implantitis, there's a heck of a lot more bone loss, especially in a vertical manner. I wish this wasn't the case, but one of the very first studies that began a wake-up call for us was in the Journal of the American Dental Association, July 2014, suggesting that when excessive bone loss was indicated, about 18.7% of implants were classified as failures. They begin also to talk about a history of severe periodontitis as being the risk factor. I'm indebted to Stu Fromm, where I saw this slide and had to have it, but these are the implants sold, and if just 10% of the 2,700,000 implants, if just 10%, that would be 273,000 implants that would be lost, and over 5 years, that would be 1,365,000. And I can suggest to you that when you extract a tooth on a patient, yes, they're not pleased, but there's not a one of you where you've ever taken an implant out or told a patient they were going to have an implant out. I don't think you got the same response. Why? Because this is what it costs, and I'm indebted to Scott Fromm for putting this in Dental Economics a few years ago. This is what it costs to have an implant placed. This is what it costs to remove the implant and place it again. What's my point? Friends, let's not lose implants. Let's not lose implants. So when you look at implant failure, everyone wants to talk about a reason, from size to diameter to attached gingiva. But let's go back to the American Academy of Perio. What we know by meta-analysis, systematic studies, it is a history of chronic periodontitis is by far the #1 risk factor. Please appreciate that, even in an edentulous patient. #2, naturally, poor plaque control skills, but also not coming in for regular maintenance. You can take these 3 things to the bank. Now, possible outliers are smoking, diabetes, cement, attached gingiva, positioning of implants. But I suggest that there's going to be a time that you and I are going to come back and say, you know something, occlusion was also a critical factor in implantitis. Just hang on. Oh yes. Sometimes I think we place implants to get XM stations, radio waves, not sure. Our implant placed in the upper right is one of the most interesting custom abutments I've seen in a long time. But you on this call are not like that. And I hope you're not like this. These are cases. Not sure what one was thinking about the implant placement on the lower center. Not sure about the root proximity or implant proximity on the lower right. But these things do happen. So the risk factors in peri-implantitis, again, from the World Workshop, Schwartz, Dirks, Ange, Homley Wang, histopathologic clinical conditions leading to conversion from peri-implantitis to from mucositis implantitis are not completely understood. It's not just biofilm. The onset of peri-implantitis may occur early during follow-up, but is not necessarily linear and can be accelerating. At histological compared to periodontitis sites, these sites have much larger inflammatory lesions, and guess what? Circumferential bone loss. This is what we see, and it's not necessarily linear. And I'm going to give you a couple of thoughts. One is, I think the body is saying, you know something, I don't want you anymore. I think the body is saying, you know, this is a foreign body. And what does the body do with foreign bodies? It gets rid of it. Hold that thought. I hope you also appreciate that not every implant surface is the same. There are anodized, SLA, calcium phosphate machined. Not every implant surface is the same. And not every implant surface reacts the same with the progression of implantitis. I'm indebted to Tom Wilson. January 2015, Journal Perio began to talk about what? Foreign bodies, primarily consisting of titanium and dental cement particulates, were found in the inflammatory infiltrate and starting to ask about the role of foreign bodies. Since then, there have been other studies describing something at the level of even corrosion. And it may be one of the reasons why we're starting to see more and more of these ceramic type of implants that are out there. I think the jury is still out, but I know they're being marketed against titanium for the reasons I've just suggested. But understand, there's a substantial number of implants out there that are very, very functional. So let's you and I talk about how to deal with these things. This is the typical stepwise surgical outline for managing implantitis with an open flap. I'm not going to go through all 13, but there's a lot of things here. Reflect the flap, debride the defect, air power abrasives, sterile saline, tetracycline strips. Let's go back again, throw in some more air power abrasive. What the heck, let's put some chlorhexidine in there. Another 60 to 90 seconds of sterile saline. Again with the air power device, but no powder this time. Let's put some biologics with Emdogain. Then let's put some bone in there. Why not? Let's go ahead and cover it with a couple of membranes. And then we're going to release the flap, coronally advance. And if you really want to do this right, take off the abutment and bury the thing. Well, here's the problem. Ka-chink, 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 ka-chink. There's got to be a better way. Not to say that this doesn't work, but there's got to be either using some of these things, barring some of these things, but moving forward. I'm not so sure this is it. Let's you and I begin to have a conversation right now. What are we trying to do? Why are we doing, what are we trying to do? I would suggest to you that I've always relied on my 3Ds, including with Peri-Implantitis. I degranulate, I think that's wise. Detoxify, sounds good to me. And decorticate. And I think that no matter what you do, if you don't do those three things, you potentially are going to have difficulty in getting the type of regeneration that you want. Look at that defect. Substantial defect. And again, here's someone doing something that I highly recommend that you don't do, and that's use a diode. Oh, you will probably detoxify to a certain degree. You may degranulate. I know you can't decorticate because it's a diode. You're definitely going to kill the bugs because you're probably frying the implant at the same time. My personal preference, don't do it. And when you start to fry those implants, here's what happens. You get melting, you get cracking, and these, my friends, are implants. But a series of studies began to occur around 2011, 2012. I'm indebted to our group in Japan, followed up with Mark and Ron Nevins. And what they began to demonstrate is that when you used an erbium laser on an implant surface that you see over here on the right versus over here on the left, that for whatever reason, the bone began to reintegrate more effectively over on the right. So what was the laser actually doing? Well, we know it's killing the bugs. We know that there's probably nothing better out there to degranulate an osseous defect than an erbium or a CO2 laser. But for the most part, it may be that the laser is actually removing the tyenite particles and actually creating a surface by which we can get new osteointegration. And so now there are more and more studies coming out about the fact of when we talk about decontamination, it's not just about the biofilm, but it's also about affecting the implant surface itself. And this is a series of studies using the erbium chromium YSGG on the SLA, demonstrating that it did affect positively the implant surface without actually creating an adverse event. And we're starting to believe that most of that is due to photoacoustics. And now with studies using the erbium chromium YSGG, we're starting to see osseous fill. Oh, not perfect, but not losing the implants. And we're starting to see studies. This is from Rana Al-Falaki out of United Kingdom, in which mean pocket depth decrease was 2.9 millimeters at the end of 6 months. And this is Todd Jorgensen in Arizona with a series of cases where he didn't even take the implant off and used something that he used a series of steps using an erbium chromium YSGG and seeing the result with the bone regeneration. And I ask you, if you're going to use laser, begin to use lasers that can not only remove the granulation tissue on the outside of the threads, but can actually do something to decontaminate on the inside of the threads. And here's a novel way of doing this. This is a laser tip that actually, from a side firing energy, fires the energy straight into the threads. And you can see in a study below of where we use cement in the threads, and here's after using the tip, and it did not adversely affect, but actually removed one of the hardest cements there are that exists in dental materials. And likewise doing decortication. And if you're interested more, here's one of the most recent studies with erbium. This is Don Clem. We're using erbium YAG, but also now doing something called adding biologics. So here's the bottom line. If you're going to manage implantitis from the chair side, please try to remove the prosthesis. And if the bone resorption is 25% or less, there are novel ways out there using lasers that you can use the laser tip without reflecting the flap completely. I like to do mini flaps, but if the bone loss is more than 25%, then you've got to reflect the flap. You've got to see. Remember, circumferential. You got to detoxify the implant. And depending upon the osseous topography, you may want to consider with bone augmentation and biologics. For those of you that are appreciative of third-party coding, I thought I would add the D6101 for you, D6102 for you. These are the codes that are used for debridement and for our peri-implant defects. And you would want to go back and look at your ADA code book to redefine, but for the most part, this is what we use. So, in conclusion, early detection and diagnosis is absolutely critical. Can I ask you that when you see suppuration, when you see bleeding, when you see the telltale signs of inflammation and there's no bone loss, please treat it as if there was, from the standpoint of not just telling a patient to brush better. Show them the ways they can use with the interdental brushes, but also you take whatever you're going to need and go in and do some type of biofilm removal, removing any supragingival calculus. But I guess the most important, if you're seeing this, don't bring them back every year. Bring them back every 3 months. They put a lot of money into that. You put a lot of time and energy into that. I don't want to see a negative backlash about the placement of implants. The access to the implant by both the hygienist and the patient is an absolute necessity. And please, restorative practitioners, please be thinking about that. It's not just placing the implant. It's not just about it looking pretty. Someone has got to get in there and do something about disruption of biofilm. And if they can't, then let's just hope that they have such a great genetic portfolio that nothing's going to happen. What you use on a tooth cannot always be used on an implant, and I hope I've stressed that to you. There is no dentin on an implant. There is no abutment on a tooth. So please appreciate that you can't use the same stuff in your armamentarium. And present evidence shows there is a major reason for using lasers to manage implantitis and should be in the armamentarium of all of us who place implants, who unfortunately will be seeing implantitis in the future. As I always say, the difference between a failing and ailing implant is when I place it. No, it's actually when you place it. I only place ailing implants. And look forward for new stuff on the horizon because it's a coming. Thank you so much for taking the time out of your day to be with me. If you want a copy of this presentation, if you would email me at slow@dental.ufl.edu, I'll be more than happy. The email will go to no one but to me and you, because it's very important that you and I should be sharing.